So, good morning. Let's have a look again at the presentation on the health system, which we've seen again, which we've seen before. It will surely bring back some memories, and we won't have the time today to look at all the presentations on the health system, but I will upload them so you can read them later when you have the time to do so. So starting with the health system as a whole, and then some details on the elements of the health system. So by default, when we say healthcare, we mean all activities inside the country directed at the betterment of health of the whole population. So by default, this healthcare is an intersectoral effort. So all ministries, agencies, etc., whatever's present in the country should be involved in healthcare. For example, if you improve traffic safety in a country or solve the problems of air pollution, clean drinking water, etc., it's all healthcare, even though the Ministry of Health will not be directly involved in such things. And normally, when we say the health system or healthcare system, we rather mean, in a narrower sense, the whole network of medical specialists, of medical personnel working in individual practices, medical centers, hospitals, etc. And all of this system, in a narrow sense, is either run directly by the Ministry of Health, if you have some sort of state healthcare in this particular country, or maybe they are not owned directly by the Ministry of Health, but at the very least, their activities are heavily regulated by the Ministry of Health. This will happen even in countries which have more market-based healthcare. So this is the general logic here. Of course, the focus in modern healthcare is on health. That's because it's cheaper, because it's more effective. The focus is also on primary care, and also because of the nature of modern diseases. The modern healthcare system should be oriented more towards the prevention, early detection, and follow-up on chronic conditions than anything else. So conditions accompanied more by disability than by direct mortality. So there are some differences, of course, with the traditional healthcare known from the past, from the previous century, which was focused more on hospital care. So the term is quite proper. The term is quite proper. We call it healthcare. We call it Ministry of Health. We don't call it Ministry of Hospitals or Ministry of Treatment or something like this. It is no wonder that it's called Ministry of Health and Healthcare. Okay, so about the elements of health of the health systems. The health system is hierarchically built, so it's represented graphically as a pyramid, like the population pyramid in demography. The broad basis of the health system, this is primary care, then you have secondary and tertiary care, and they are linked together by the referral system. The broad basis here in the concept of the WHO means that most resources should be directed towards primary care nowadays, and that most diseases should be treated there. And what's primary care? What's the first level of healthcare? It is this type of healthcare that is provided at the home of a patient or close to his home. So primary care includes general practice or family medicine, whatever is present in the country, emergency care, urgent care, specialized outpatient care, and things like hospices, nursing homes, homes for the elderly, etc., etc. All kinds of medical centers, of course. Then you have secondary and tertiary care, which are hospital care. Hospital care is, if secondary care is hospital care that is territorially based, so these are normal, regular hospitals who service the population from the immediate vicinity, then tertiary care is super specialized hospitals that service population from the entire country, and sometimes even other countries. Now, of course, underdeveloped countries do not have the third level of healthcare. They don't have tertiary care. As for the referrals, the WHO would prefer to see its member countries having a system of mandatory referrals. So no patient should directly access secondary or tertiary care without a referral from a primary care physician. That's because primary care is better suited to address non-communicable diseases, and that's because treatment there is considered more effective, it's cheaper, it's more convenient for the patient than the traditional hospital care offered by secondary and tertiary care. So this is, of course, a change that happened in the end of the 20th century, the reorientation from hospital care to primary care. So that's it in general. Here on this slide, you also see the concept of universal healthcare. Universal healthcare means that all citizens in a country that has achieved universal healthcare or universal health coverage should have access to healthcare. It should be available to all citizens. Available financially, meaning it should either be completely free of charge or it should come at an affordable price for the population. And second of all, it should be logistically available. So there should be hospitals, medical centers, etc., evenly distributed along the territory of the country so that everyone can visit a medical center, hospital, whatever's the need close to his home. What else do we see on this slide? These are some important priorities of modern healthcare: quality, efficiency, and equity. Now, equity means basically no discrimination. So all patients are treated equally, regardless of no sort of discrimination is allowed in modern healthcare based on race, gender, ethnicity, religion, etc., etc. That's the idea. Efficiency means basically economic efficiency. So an input of less resources, but servicing more patients at the same time. That's efficiency. What does resources mean? It's the same as in the general economics. So resources mean human resources. So the healthcare system should have enough doctors, nurses, etc., plus material and technical resources. Material resources means things like equipment and vehicles, buildings, etc. Then financial resources, money. And finally, the time resource, which is more or less, of course, the same for every health system across the globe. But here in this context, it means a rational organization of working hours. And quality. So what does quality mean in the context of healthcare? As usual, as in the general economics, quality has an objective and subjective component. The objective components of quality in healthcare would be proper, correct diagnostics and treatment. Is the patient correctly diagnosed and treated and timely, of course? Of course, the patient is unable to himself assess the objective component of quality. He's incompetent to do so, but here another aspect of quality appears, the subjective component, and it translates to satisfied patients in the end. So patient satisfaction should be measured through some kind of sociological surveys inside the health system. So patient satisfaction is a result of what? If patients are treated kindly, with dignity, then there are receptions in all of these individual practices, centers, hospitals, that schedule reception hours and then stick to them. If there's high hygiene and pleasant sites in medical centers and hospitals in the country, the personnel is kind, etc., etc. These are things that the patients can actually experience themselves, so it would lead to higher patient satisfaction. So, some examples here of the broad definition of the health system here used sometimes. So if we equate the health system to the entire healthcare, you can see some examples of health activities. that are included in the scope of healthcare. So again, healthcare is not necessarily just a network of hospitals and other medical facilities inside the country. Universal health coverage. So how far have countries progressed towards universal health coverage? First of all, why do we need universal health coverage? That's because healthcare is a unique economic activity. Inside the general economics of a country, you have all of these sectors of the economy, like the transportation sector, for example, agriculture, industry, etc., that are based on the principles of the market economy in modern developed countries. Market economy meaning what? This market-based economy operates according to the principles of supply and demand, and where the curves of supply and demand intersect, you will have the equilibrium prices, which are more or less right for the producer and the consumer. You have marketing. So all producers will try to aggressively advertise their goods or services. In the context, of course, of economics, services means goods that are consumed at the moment they are produced. That's the difference. And this normal, so to speak, economy produces the so-called luxury goods or services. Luxury goods are such goods that the consumer may be denied access to based on his inability or unwillingness to pay the price asked for by the producer. So a luxury car, for example, a very expensive car, or yacht, or a private jet, something like this. This is an example of luxury goods. For example, you would like to buy a nicer car, not some old, decrepit car, but you can't do this because you can't pay the price at the store. This makes you unhappy, but basically no one cares because this is not considered essential goods. This is considered merely as an expensive toy. So this is what the economy of a country mostly produces: luxury goods and services. You can live without them. But then you also have the so-called public sector of the economy, and it's important to notice that the public sector of the economy also exists, and it provides services and goods to the population that are considered basic and essential, meaning that they are in fact equated to basic human rights. So every citizen is entitled to receive them, regardless of whether he is able to pay for them. This is what the public sector of the economy is about. And in order to guarantee that every citizen receives these services, all countries, despite of their normally market-based economies based on market principles, on the principles of free competition and unregulated prices, will in fact either directly own this sector of the economy or heavily regulate it. So, what's included in the public sector of the economy? Education, social security, so all kinds of social services, external security, so the armed forces of the country. Now, it would be, of course, extremely funny if all external security in your country is provided by private armies, right? It would be a sure sign of a failed state. Or if all education in your country is private, so only wealthy families would be able to afford education for their kids because they can pay the taxes in private schools. Apart from external security, education, and social services, it includes internal security, this public sector of the economy. Internal security means police and fire departments. Again, no sane country would, of course, rely on private police forces competing among themselves here. There will be a state and maybe a municipal police. And finally, apparently, healthcare is also included here. So healthcare should be provided either free of charge to all citizens, or it should be provided by some arrangements at an affordable price. It should be free or affordable to the entire population. So that's about the public sector of the economy. Now, another important thing here to notice is that healthcare in itself is extremely important for the economy because it is, in fact, the largest sector of the modern economy. So the fact is, in practically all modern developed countries, this is the largest sector of the economy. Most of the GDP is produced and spent there. There are, of course, some exceptions where healthcare is not the number one sector of the economy, but they are very rare. For example, North Korea is such a super aggressive and militarized country where most of the GDP is spent on armaments. So the armed forces are the most important sector of the economy. The entire state is geared toward war. Another abnormal state like this, mutated state, is the Russian Federation. Again, military spending is number one there. But these are countries that can hardly be considered normal. So, of course, they cannot serve as an example for other countries. The country where healthcare spends most money, you probably know this, is the United States, where almost 20% of the GDP is there in the healthcare sector. And there are many European countries where more than 10% of the GDP is produced and later spent there. In the healthcare sector, you can see some examples here. Again, if we measure the performance of the healthcare in a country by the final desired outcome, and the final desired outcome, of course, is a higher average life expectancy for the population, you should pay attention that high healthcare expenditures do not necessarily predict in a linear fashion how high the average life expectancy in a country will be. So apparently it's not just a matter of absolute spending, but it's also a matter of organization. For example, the United States are below this desired borderline that exists nowadays of at least 80 years average life expectancy, even though they have the largest healthcare spending. And this is statistics apparently for OECD member countries. The Organization for Economic Cooperation and Development, which is a sort of a global European Union, a union of the strongest economies globally. The last two countries, by the way, that were candidate countries for the OECD were Croatia and Bulgaria. Croatia was accepted last year to the organization, and Bulgaria was rejected. It's for now its membership is postponed. It doesn't meet all criteria. So as for universal coverage, all OECD member countries, which used to be 34 and now they're 35, have achieved universal health coverage. So healthcare is considered accessible, available to the whole population, with the exception of the United States and Mexico. Here's a map of universal healthcare in approximately the year 2012, 2013. So 10 years later, some other countries managed to achieve universal healthcare. So nowadays, I would add here also Turkey and China. But the United States still remain anomalous. They haven't still achieved universal healthcare even after the reforms of Barack Obama. So they're the only highly developed country that hasn't achieved universal healthcare. Public versus private expenditure. In any event, it is important that most healthcare spending is public spending. It doesn't matter if it's governmental or municipal. Direct individual or household spending on healthcare is unfeasible in the long run, as the ever-increasing medical services costs become more and more unaffordable for more and more families. After all, medical expenses in themselves are a typical example of the so-called catastrophic expenses. Now, this term catastrophic expenses appeared in the times when insurance appeared as such, because initially it was just the Lloyd's company in Great Britain. For example, a family at the time would equip an entire ship and send it across the globe to the far situated colonies of the crown. It will be loaded with some exotic spices, for example, get back home, and they'll be sold at a profit, but sometimes the ship would go missing. It would simply sink along the way or be hijacked by pirates or something like this. And then the entire family that has paid for the expedition may go bankrupt. And that's where Lloyd's and other companies later stepped in and started to offer insurance for such events. So they were called catastrophic events, and these are catastrophic expenses. That is, expenses that come unforeseen in life and are insurmountable. And healthcare nowadays is so expensive that it represents a fine example of catastrophic expenses. For example, you may fool yourself into believing that you can pay for healthcare when you need it. So, for example, you will be reluctant to pay each month a part of your income for some sort of health insurance because you're perfectly healthy and you think that it will be cheaper for you if after many, many years you finally get sick, you pay at the time when you need it, like you can buy a new car or something like this. But it turns out it's not so because, for example, if it turns out the patient has a cancer diagnosis, all of a sudden his family will know that the treatment of this person will cost millions. So a single disease has the potential to bankrupt an entire family because, of course, family members tend to support each other. They'll try to scrape for the necessary money and they won't be able to do so. So then you'll know firsthand what catastrophic expenses means. Of course, to avoid these situations, governments in modern developed countries have introduced all sorts of public social insurance schemes. They incentivize also citizens to engage in additional private insurance, or they have organized direct state healthcare. So the state has stepped in and it owns everything or almost everything in the healthcare sector and provides services directly to all people. Practice has shown, of course, that direct individual spending does not guarantee that money are spent on improvements in healthcare and not luxury goods or unnecessary services. For example, if you have many private insurance companies in your healthcare, it would be naive to think that the first concern of such private insurance companies or banks offering insurance is the health of their clients. No, of course, they will spend part of the money of their clients on healthcare, but most money they will spend on new offices, secretaries, company cars, etc., etc. So, especially in the context of healthcare, private initiative is a dead end. It leads nowhere. Okay, let's continue now. This is a list of OECD countries by health expenditure covered by the government in 2016. The closer you are to 100%, the better. You can see some countries are in the green zone, so they are considered excellent. In this respect, some countries are in the yellow zone, which is a sign of danger. And then the red zone means complete failure. This is an unacceptable situation. You can see the United States and Greece as examples here. You can see how far Turkey has advanced. All of this happened, by the way, during the times President Erdogan's party started ruling Turkey. So probably people remember, and that's why they are re-elected. Healthcare was in very poor shape in Turkey before Erdogan came to office after being serving as a mayor of Istanbul before that. So it is achievable. It is achievable. You can start from a very low basis and then quickly progress, apparently. The paradox here is the United Kingdom does not have the highest public health expenditures, even though it is supposed to have state healthcare. While in Germany and Japan, they have public insurance. It is important to note that the total amount of money spent on healthcare does not predict directly, at least, the desired health outcomes, because money can be spent on public health initiatives, improving the health status of the entire population, or it can be spent on unnecessary administrative services, diagnostic procedures, hospital surgeries, new medications that do not offer increased benefit for the patient, and so on and so forth. The United States serves as a fine example here. They have an exorbitant health expenditure, approximately $4 trillion annually. And it was 18% of the GDP something like 5 years ago. So nowadays it's closer to 20%. The obtained health results are modest and inferior to the results of the neighboring countries. Now, the United States surely has better healthcare than Mexico, but it has worse healthcare than Canada and Cuba. And this is shameful, considering that, yes, it's no surprise that the United States has worse health results than Canada, because, after all, Canada is a more developed country. It is many positions ahead of the United States in the UN ranking. But Cuba is a less developed country, and it's a very poor country, so it's quite anomalous that Cuba obtains better results overall. For example, Cuba has a higher life expectancy. Cuba has lower mortality, lower infant mortality, lower maternal mortality, etc., etc. Shouldn't be like this. Here you see this discrepancy. So this is health expenditures. This is average life expectancy. As you can see, Japan is the exact opposite. Health expenditures, average life expectancy. Here you can see another end result. The percentage of overweight and obese population. You see the percentage for the United States. And of course, it would be incorrect to blame this entirely on the population. It would be incorrect to claim that American people are stupid or something like this, and that's why they make poorer choices. So they have unhealthy lifestyles, and they can only blame themselves. See where Japan and Korea are with respect to percentage of the population that is overweight or obese. No, it's not just that. It's a matter of governments executing their control functions there, because this percentage of overweight and obese populations is mostly the result of price politics for foods in the country and control over the quality of food offered to the general population. And control over food quality is pretty imperfect in the United States, even though there's a special federal administration, federal agency dealing in that. So, yes, again, it's not people to blame, but mostly the government. The federal government, and also, of course, state and county governments in the US. Of course, when it says Korea here, it means South Korea. You won't be able to find overweight and obese people in North Korea. You probably know this. The only obese people, of course, in North Korea would be the beloved great leader of the country. He is, of course, fed Swiss chocolates, etc., but that's only him. All the rest are perfectly lean and skinny in this country. Primary care, in general. Primary care refers, like I told you, to the first point of contact of the patient with the health system, offering services close to the home of the patient. It should be universally accessible, and it represents a very wide scope of services. Primary care scope. Basically, primary care offers diagnostics and treatment for almost anything possible. As for hospital care, secondary and tertiary care, nowadays they are mostly reserved, and that's the end idea of the WHO, for super specialized, complicated services like the different types of transplantations, cancer treatment, also the treatment of large burns, treatment for rare diseases, etc. But everything that is widespread and common in the population should be addressed at the primary care level. Plus, of course, primary care is suited to long-term follow-up on chronic conditions, while hospital care is not. Of course, the hospital specialist would see a patient only for a short period of time, tackle his acute condition, and then he'll simply forget about this patient the moment he's discharged and leaves the hospital. On the other hand, the primary care physician is supposed to take care of a patient's chronic condition throughout his entire life. So imagine that the patient has diabetes type 1, which he developed during his puberty. Someone, of course, has to control his condition throughout his entire life, and it won't be a hospital physician. Secondary care. We can skip this for now. I think I mentioned enough. As you can see, secondary care also includes all kind of diagnostics. So not clinical laboratories, but medical imaging services, not ordinary microbiology, but virology laboratories, etc., etc. It also includes intensive care. This should be noted because emergency care in general has an out hospital and in hospital component. So all of these emergency care units riding on ambulances, this is the primary care component of emergency care. But then you have ICU, intensive care units situated in hospitals, and this is the hospital component of emergency care. It should not be considered part of the normal, so to speak, hospital, because the regular hospital, the rest of the hospital is based on specialized wards. So it will consist, of course, if it's a general hospital, not a specialized hospital, it will consist of a pulmonology ward, cardiology ward, etc., etc. But this particular unit, be it a ward or a clinic, the intensive care unit is part of the emergency care system. Its aim is to stabilize the patient, and then afterwards the patient will be transferred to some of the specialized wards in the hospital. And it is no wonder, of course, that they are also even paid differently. For example, in Bulgaria, a specialized ward is paid by the National Health Insurance Fund. So every Bulgarian citizen is supposed to be health insured. So he pays 8% of his monthly income. It's deduced for the needs of healthcare. It's the health insurance of every Bulgarian citizen, and the National Health Insurance Fund uses this accumulated money to pay all sorts of hospitals, and not just hospitals, of course, based on the number of patients they have serviced monthly. So the health insurance fund will pay the specialized wards according to the number of patients they have serviced during the month. But the intensive ward in the hospital will not be paid by the health insurance fund. It will be paid directly by the government. It's subsidized by the government, so it receives direct payments from the Ministry of Health. And it works 24 hours a day, not like the regular wards, and it basically admits anyone that is brought by an emergency care unit, by an ambulance or helicopter, whatever. So it's not part of the regular system. Tertiary care, as I told you, these are super specialized units inside the health system, and you'll see some examples of such activities here, like neurosurgery, cardiac surgery, neonatology, plastic surgery, etc. Of course, only developed countries would have this level of the health system, because it requires specialists, it requires equipment. Home and community care. They are getting more and more important nowadays in view of the severe aging of the population. They are probably even more important than regular hospitals and medical centers in modern countries. And the whole healthcare should be, by the way, reorganized and reoriented mostly towards providing such services, going hand in hand with social services. So, considering that in the long run, aged people would be the primary client of healthcare, the healthcare system should be duly reorganized to meet their needs mostly, and not the needs of younger patients, which are missing anyway, who are missing. And this reorientation, the reorganization of the entire health system has already quite advanced, especially in northern European countries. Okay, you can see some examples here of home care, assisted living, different arrangements may be used in different countries. Now, what does the term providers mean in the context of the health system? Anyone that is officially licensed, registered according to governmental educational criteria and plans. So the healthcare provider may be an individual physician or other individual health specialist. It may be a group practice, a center, an entire hospital. Here you see some examples of medical professions. Now, of course, with the exception of traditional medicine practitioners and chiropractors, because these are all valid for North America, the Far East, and Europe, the developed countries, but these are valid for North America and to some extent the Far East. These people are considered charlatans in Europe, so they will not be officially registered and licensed in Europe. All the rest, of course, is valid for the entire developed world. So, what are the methods of paying medical practitioners in general? General taxation to the state, county, or municipality. So you see this in countries with the state healthcare. So what's state healthcare in essence? The government collects all its money from taxes at the end of the year. And then the financial ministry redistributes money obtained from general taxation. So it will mostly be the income tax, the consumption tax. For example, the Ministerial Council has decided that 5% of the spending part of the gross domestic product for the next year will be spent on healthcare. This means that 5% of the spending part planned for the next year will be transferred from the financial ministry to the Ministry of Health, and then the financial department of the Ministry of Health will use this money to support the healthcare system. So the arrangement is pretty simple and straightforward in state healthcare. Then you may have countries with national health insurance, so they'll have one fund where everyone has to pay premiums, so monthly deductions from their incomes, and money accumulated there will be used to pay for the services of centers, hospitals, etc., that have signed a contract with the health insurance fund. And the contract stipulates the fund will pay for these and these services at these and these prices. So that's national health insurance. It works a lot, of course, like the social security system, because normally most developed countries would have one such mega fund for social insurance where everyone will get insured in order to receive a future pension when you retire after the age of 65. Then you have countries with so-called public or social insurance, where the scheme is the same, but there are many funds, public and sometimes private, offering coverage of their enrolled patients. Of course, it will all be regulated by the government, so they will all use the same premium and the same scope of services to be covered. Then you may have private insurance in some countries. Private insurance is less regulated. It means that different private insurance companies will offer different packages of services to be covered, and the premiums will be different. So based on your individual risk, patients will pay different deductions of their monthly incomes to the funds, the health insurance funds, the health insurance companies. So this private insurance will not look like the retirement system, the social security system. It will look like auto insurance. You have your individual insurance with individual financial conditions, according apparently to your individual risk. So in the context of auto insurance, for example, car insurance, if you are a young driver, you will pay more because you're considered risky, reckless. You are far more likely to engage in crashes, in incidents, and incur expenses on the insurance company. In healthcare, it will be just the opposite. If you're young and healthy, you're not expected to get sick, so you pay less because you pose less of a risk liability for the insurance company. But if you are old and obese with many chronic conditions, you will pay, of course, a very high monthly premium to be insured. Okay, then you may have reliance on direct out-of-pocket payments in some countries. This will be typical, of course, of underdeveloped countries. And in some places, they will even rely on these donations. Providers payment. In most countries, wage costs for medical professionals estimate between 65 and 80% of the health system expenditures. So most money, of course, in healthcare will be directed towards wages. And these are three general means of paying medical professionals. Fee for service means that each medical procedure will be priced separately. When you have a price list of services, you'll be paid according to the actual manipulations, procedures you have performed during the month. The fee-for-service mechanism is mostly used in countries with market-based healthcare, also in some countries with public insurance, like France or Belgium, for example. Then the capitation payment system will be used in some of the countries with state healthcare or national health insurance. Medical professionals here, GPs, general practitioners, for example, will be paid according to the size of their list, patients list. So, for example, you take care of 2,000 patients, included in your list of patients enrolled there, then you receive 2,000 euros per month. If there are 4,000 people there, 4,000 euros. That's the capitation payment per capita. It doesn't matter whether you've actually serviced them during the month or even seen them, but you'll still get your money. And finally, you have the firm wage or salary. That's strictly, of course, typical of countries with state healthcare, where you have a fixed wage according to your rank in the system. For example, if you take a look at the British healthcare, which is state healthcare, hospital doctors in general would be employed by the NHS. The state health system, the National Health Service. And then you have a wage according to your rank in the system. You'll start as a junior registrar, and one day you'll possibly progress to senior consultant in the system, and then your wage will be very different. But general practitioners are considered theoretically independent doctors in the UK, just theoretically, because then they sign a contract with the NHS, and they are paid by the NHS according to the capitation system, so according to the size of their patient list. If you take Bulgaria, general practitioners are again paid according to the capitation system, but hospital physicians will be paid by the National Health Insurance Fund according to the number of patients they have serviced. So there isn't a fixed wage for them, for hospital physicians. Okay, and if you enter emergency care in Bulgaria, since it's state-owned and operated, you'll see fixed wages, fixed salaries, like in the UK system for hospital physicians. Some hospital performance indicators. Here you will notice some peculiar things. For example, it turns out that hospital care is very high quality in the United States for those who can afford it, of course. So the results from such indicators of hospital-based treatment would be excellent for the United States. As you can see, they're always in the green zone. Then you see some pretty unconvincing results for countries with state healthcare. You can see where the UK is. But this should be considered normal. When we take a look at the broad priorities of healthcare, If one priority is access to services, one important priority is access. So 100% of the population having access to healthcare. From this point of view, the best type of healthcare is, of course, state healthcare. It will achieve universal access. It will be closely followed by national health insurance, then public insurance, and surely market-based healthcare, the liberal model, would be the worst. So, according to access, state healthcare, of course, wins. So, the result in the match is 1-0. The state healthcare scores a goal there in access. Then, if you assess healthcare on the basis of, so the second important direction in which it is assessed in general is quality, then it's just the opposite. State healthcare has the poorest possible quality of services, and private healthcare has the best possible quality of services. So then the result gets 1-1. So the match, of course, is going to be decided on which form of healthcare is superior by the third priority, which is effectiveness. Considering that healthcare is getting more and more expensive nowadays, it has the potential to ruin, to bankrupt an entire country, just like the social security system. And you probably know this already. In Greece, how hard it is to support the social security system, how it can bankrupt the whole country. Healthcare can do the same. It is very important for the healthcare system to be as effective as possible. So obtain more results with less resources. With less money, you get more patients being serviced. So it is very important to find out here what is the cheapest model of healthcare. And here again, there can be no doubt about these results are striking, unequivocal. The cheapest possible model of healthcare is state healthcare. So all poor countries or countries having difficulties in meeting their annual budgets should always choose state healthcare. Without any doubt, the most expensive possible model of healthcare is private healthcare, market-based healthcare. So, and of course, public insurance and national health insurance are somewhere in between. Again, not so good, not so bad either. They are like that. Pretty mediocre in terms of everything, in terms of quality, of access, of effectiveness. So apparently, objectively speaking, state healthcare is the superior model. It wins the match 2-1. Okay, so we are not surprised to see somewhat poorer quality of services here. And then you have here Eastern European countries and Mexico in the red zone. We're not surprised to see this. Types of healthcare systems. Now, a few notes again on the general organization of healthcare systems. So, the business side, where the money comes from and what it can buy, which is, of course, important in the real world. Types of healthcare systems. You should note here that, in fact, every health system is unique. Every system is unique, And it is in fact a complex mixture of elements from the different possible models of healthcare, the different possible types of health systems, because these types that I mentioned so far are theoretical. So in fact, you have a mixture of elements of all types in the different health systems. But when we say that, for example, the UK has state healthcare, or Canada has national health insurance, or the United States has the liberal model, it means that it has prevailing features of this model. So after this warning, let's see the four basic types of health systems. And then, of course, every country globally will opt for one of these four types. If it's, of course, a democratic country, so something the type of Iceland, Greenland, Switzerland, they'll hold a referendum on such an important issue. They will explain the population what they're going to gain and lose with each type of healthcare system, and then the population will decide what's more important for them, and they will vote on some type of health system to have. If the population values access to healthcare for everyone, most of all, they will vote for state healthcare in the country. If the population feels that it is important for the economy to remain stable, for the entire country to not get bankrupt, etc., to stay afloat in tumultuous times, they will again, of course, vote for state healthcare. If the country values quality of healthcare, first of all, or has the idea of justice, so you get what you pay for, then they will, of course, vote for market-based healthcare, for the liberal model. And that's, of course, the ideal situation. Most countries, of course, across the globe are far from being democratic. So instead of the citizens deciding what type of healthcare they would prefer to have, it would be a small group, of irresponsible politicians who will meet secretly and decide secretly what type of healthcare to have for the country, because they are used to this type of thinking. Politicians in undemocratic countries, that they're somehow superior to all other citizens and they can decide instead of them. They know better. Even though, of course, we know it's just the opposite. They know nothing. So their decisions are, in most of the time, decidedly wrong. For example, Bulgaria changed its model of healthcare, its philosophy of healthcare several times in modern history for no apparent reason. No one knows why Bulgaria switched all of a sudden from public insurance to state healthcare and then to national health insurance, but this is what you get when you empower politicians to decide for yourselves. So, the four types. Let's start with the so-called Beveridge model. It is named after William Beveridge, one of the social reformers who designed Britain's welfare state after the Second World War. And an important element of this welfare state that was promised to the masses after the successful end of the war was the National Health Service. So state healthcare that is readily available to all citizens, free of charge. In this system, healthcare is provided and financed by the government through tax payments, just like the police force or the police or the public library. So it's a state service directly offered to all people. Many but not all hospitals and clinics under this model are owned by the government. Some doctors are governmental employees. There are also private doctors. In Britain, you never get a doctor's bill, and then you never get also a prescription bill. For example, in the UK, they only have the prescription tax. It means that no matter how many drugs you've been prescribed, you still pay the same administrative tax for being issued the prescription. It's several pounds. I once received a guest, a friend of mine from London, and he asked me, so are you trying to tell me that Bulgarian patients pay themselves for their medications, for their drugs? And I said, yes. And he said, what, all of them? Yes, I said, they pay for all of their drugs. He said, how are they able to do this, especially the pensioners? How are they able to buy all the drugs they need? The pensioners in Bulgaria, considering the pensions they receive. And I said, I don't know. It's a miracle. No one knows. So you don't have, of course, this problem in the UK and in many other countries with state healthcare. These systems tend to have low costs per capita because the government, as the sole payer, controls what doctors can do and what they can charge. Now, even hospitals, by the way, in such a system in state healthcare are paid according to historical budgets. So they are effectively fixed budgets. Because all public hospitals are part of a health map, so they are supposed to service a certain population, and the needs of this population are pre-planned according to demographic and epidemiology data. It's all part of the health map. Each hospital, in fact, here receives a fixed sum of money. So each year you get the same. Yes, maybe a bit extra to compensate for the inflation, but that's all. So, of course, there are no large and unforeseen expenses here. While, of course, countries that have public insurance or private insurance, well, of course, everyone there is engaged in swindling all the time. You always make up more patients that do not, in fact, exist, or make up more complicated forms of the disease, and then you present such monthly records to the insurance fund and demand that they pay you. And they are pretty lousy at doing their job of controlling expenses. So very rarely they are able to prove that, in fact, your patients were not as ill as you claimed them to be, and then you simply made up some of your patients. They did not exist, in fact. And we had, of course, one such case recently. One of the many, of course, when the hospital where you study managed to make up 40 patients out of thin air that were supposed to be hospitalized in the hospital, but of course they never came to the hospital. No such patients existed, and the hospital managed to get a payment for them from the National Health Insurance Fund, and it happens everywhere where you have such insurance schemes. It's a constant, hide and seek game between the provider and the third party payer. So expenses for supporting an insurance scheme, be it public or let alone private, are very high and very unpredictable. It's like a black box where money go and no one knows what they're spent for. But this doesn't happen in state healthcare. Everything is pre-planned here. So again, this is the suitable system for countries with limited budgets. Countries using the Beveridge Plan or variations of it include Great Britain and the UK as a whole. And they'll have, of course, separate systems for the different parts of the country. So they will have NHS England, Wales, Scotland, Northern Ireland. Also Italy, Spain, Scandinavian countries, New Zealand, Hong Kong, even though it's already an autonomous region of China. Countries, of course, like Cuba, North Korea, Belarus, so strictly communist countries, not lex communist countries like China or Vietnam, represent the extreme application of the Beveridge approach. And it's the world's purest example of total governmental control. It's called the Semashko model, named after Nikolai Semashko, who was the first health minister of the Soviet Union. In the Semashko model, which is apparently a modification of the Beveridge model, though it appeared historically first, you only have governmental ownership in healthcare. So everything is state-owned. You don't have private hospitals, you don't have municipal hospitals, hospitals belonging to churches, foundations, etc., etc. Everything is state-owned. That's the Semashko model. Now, next, the Bismarck model, also called social insurance or public insurance. It's named after the Prussian Chancellor Otto von Bismarck, who is credited with inventing the welfare state. It was part of his policy of creating Germany. You probably know that Germany is a relative newcomer to the political scene because no such country and no such nation existed before. In 1861, Italy appeared in Europe. Of course, no such state or nation existed up to this point. In 1871, so 10 years later, Germany appeared. It was, in fact, the Kingdom of Prussia who conquered all the other Germanic kingdoms by force, unifying them in a new state called Germany, of course, entirely by force. It wasn't a voluntary act. And as you know, they did not manage to annex some of the German countries who remained independent, managed to evade Anschluss. For example, Austria, Switzerland, Luxembourg managed to evade this fate, but everything else was included in Germany. The Czech Republic also managed to evade this fate, and it exists separately. And of course, nowadays, Russia is trying to do the same. By force, annex all countries that it pretends are part of this parts of this unified Russia. What's part of it, of course, is just a matter of imagination, how far your imagination goes. Of course, Hitler and other Nazis believed that such thing as Germany and Germanic people existed before the 19th century, but that's pure fantasy. That's a fairy tale. Instead, you had Bavarians, Saxons, etc., etc. So, after its appearance, by the way, this new state, amazingly, like the United States after its appearance, quickly became a superpower and began to set the tone in not just in world politics, but also in technology, science, medicine, etc., etc. So when they proposed this system of what they called sickness funds for patients, it was widely imitated afterwards, copy-pasted across the globe. So many countries nowadays, in fact, have this German system of insurance for sickness, which in fact apparently copies the social security system, the retirement funds. Initially, these sickness funds were occupationally based. So, for example, you have a sickness fund for all dockers, drivers, sailors, etc., and their families. It's not true any longer. Nowadays, the system is territorially based. So funds exist according to the existence of the different federal provinces, which of course are the historical Germanic, so to speak, kingdoms. Now, these sickness funds are financed jointly. That was the German idea, by employers and employees through payroll deduction. So, for example, when this mechanism is imitated in Bulgaria, theoretically 8% of your monthly income is due to the health insurance fund, but in fact 4% is paid by you directly, 4% is paid by the employer. That's how it works. It's the same everywhere where they have the public insurance model. Now, unlike the US insurance industry, which is based on private insurance companies, Bismarck-type health insurance plans have to cover everybody. So the idea here is to provide universal access. Germany, in fact, has less than 2% of the population uninsured, which is not the case for the United States. Also, it doesn't really matter whether you have public or private insurance funds here. You have some public funds, you have some private funds. Because all the volume of services covered and all prices of physicians' examinations and any other procedures are government set. They are regulated by the government. And these funds do not make a profit and they don't compete among themselves. So it doesn't really matter how many of these you have in the country. There is no element of competition. Doctors and hospitals tend to be private in Bismarck countries. For example, Japan has more private hospitals than the United States, which is a paradox. And by the way, Japan has the highest number of funds, insurance funds. If Germany has several hundred of them, Japan has several thousand insurance funds. This is a multi-payer model, but tight regulation gives government much of the cost control clout that the single-payer beverage model provides. What's this cost control? Well, of course, it's extremely important that costs are kept as low as possible. So you will, of course, exert pressure on pharmaceutical companies, distributors, etc., to set their prices of surgical materials, drugs, vaccines, etc., lower, so that they come at the final lower cost for the population in the country. And to keep, of course, the general expenses for healthcare as low as possible, considering that you need more than 10% of your budget anyway to support the healthcare, the modern healthcare system. Now, the Bismarck model is found in Germany, also France, Belgium, the Netherlands, Japan, Switzerland, and all of the more highly developed Latin American countries. So if you see countries such as Costa Rica, Chile, Uruguay, etc., Argentina, then of course you'll find the same model there. The national health insurance model is a modification of the previous model. The system effectively has elements of both Beveridge and Bismarck. Again, private sector providers, but payment comes from a single government-run insurance fund, and every citizen has to be enrolled there. Since there's no need for marketing, no financial motive to deny claims, and no profit, these universal insurance programs tend to be, of course, much cheaper and simpler administratively to run than the American style of private insurance. And the single payer tends to have considerable market power to negotiate for lower prices. In fact, in Canada, they have the lowest prices for drugs anywhere in the world. So that's why, of course, many Americans living in the northern states will cross the border to Canada to buy their drugs there. And then you have the reverse flow as well. It's not all roses, because Canada, on the other hand, even though everything is supposed to be free of charge, but it has waiting lists because things are planned. So you can wait for months and sometimes even years to get your planned surgery, treatment, etc., in Canada. So, of course, many Canadians that are better off, so richer citizens, will lose patience and travel to the United States, where they'll pay a lot of money, but they'll be immediately serviced and they'll receive high-quality hospital services. So there are, of course, advantages and disadvantages to having state health care or national health insurance in the country. Now, the national health insurance system is found in Canada, Taiwan, which is, of course, officially the Republic of China. You know that both the Republic of China and the People's Republic of China claim to be the legitimate China. So they're both called pretty much the same. Not quite the same, of course. Also in South Korea, Russia, Bulgaria, all of these countries have national health insurance. And finally, the out-of-pocket model or liberal model or market-based healthcare, which is basically a mess. In underdeveloped countries, this model effectively means You can get healthcare only if you can pay for healthcare. And sometimes it's even barter economy. You have to exchange something for medical service. And amazingly, China used to be like this up until recently because state healthcare was in a disarray in China, but that's before Xi Jinping came to power because he's a hardline communist, so he brought China back to strict communism. They ceased experimenting with the market economy. It's quickly losing ground in China, so they're back to communism like it was in the Soviet Union. So China is the new Soviet Union, and they restored state healthcare. They're in the process of restoring it in China. Guiding principles and why choose one model of healthcare over the other. Again, a quick reminder on this. Market healthcare would be the easiest to organize and operate in the country. It will grow on its own. You don't have to specifically organize it. It will self-organize, basically. Driven by profit, this type of healthcare will guarantee high quality of health services, as both medical personnel and medical companies will be highly motivated to work and innovate, but with limited access to health services. Basically, this model is the best possible model for us doctors. But since unfortunately, the goal of healthcare is not to provide highly paid jobs for us doctors. Amazingly, the goal of healthcare is to provide medical services to people. So reluctantly, we have to step back here and admit that market healthcare is not a good idea, because it's the best model for us doctors, but it's the worst model possible for patients. So we'll have to make a compromise here, even though we don't like it. If you ask us, we should have market-based healthcare and no governmental regulation everywhere across the globe. State healthcare, on the other hand, guarantees universal access to health services, low costs, easy achievement of public health goals. Yes, I forgot, sorry, to mention this. It will be, of course, quite easier to organize all kinds of health promotion and disease prevention in a country with state healthcare. It will be extremely hard, if at all, achievable in a country with market-based healthcare. Also, state healthcare would provide better reaction to health crises and disasters. So if you have an infectious epidemic, if you have war, radiation accident, an asteroid hits Earth, whatever it is, the kind of crisis you have, catastrophe, state healthcare is the only model of healthcare that will guarantee an adequate reaction here. Practice has shown that all other models of healthcare, when faced with a huge health crisis, simply fall apart. They are completely inadequate there, and they will stop offering medical services to the population. It will be left to survive on its own. In peacetime, of course, state healthcare is not necessarily the best model, but in times of crisis, that's the only safe and sane option. This model will go hand in hand also with poor quality of medical services. Where you find this poor quality, it will be different from country to country. In some places, you'll see long waiting lists of patients to be serviced. In some places, you'll see decrepit state hospitals falling apart, rude and unmotivated health personnel, etc., etc. Poor quality is absolutely inevitable here. Objectively speaking, from an utilitarian point of view, so utilitarianism, of course, is a political philosophy that underpins socialism and communism. It says that whatever benefits most citizens is the best possible course of action. So, of course, from this point of view, state healthcare is the superior model. And all other options are failed experiments. The case of the United States. In fact, you can't really support pure market-based healthcare in a truly developed country. Now, the last European countries that gave up on market healthcare, so countries like Malta, Switzerland, Cyprus was the last to do so, did that because of high expenses. In the case of Cyprus, for example, it was, of course, one of the preconditions of international creditors to reform healthcare. But the United States continue to support market-based healthcare. They consider it a more just model. It appeals to the liberal and the Republican philosophy, political philosophy, and it offers higher quality. But even they have, in fact, some mixed model with features of the different models. So let's take a look at the example. The four models should be easy for Americans to understand because they have elements of all of them in the fragmented national health system. The servicing of veterans, that is military personnel and their families, is in pure state healthcare in the United States. Then for eligible citizens over the age of 65 or that are very poor, you have the Medicare and Medicaid funds that operate like the national health insurance funds of Canada, for example, or Russia or Bulgaria. Then the United States would somewhat resemble countries like Germany and Japan. If you are a working middle-class citizen, but then again, private insurance is somewhat different from public insurance because payroll deductions, premiums, prices of medical services would be different for different categories of patients. You will have a ceiling of expenses. You don't have this in public insurance. Meaning that you can spend up to a certain amount of money on your treatment, and then you'll be left with no coverage. You have to scrape money for yourself. And the money accumulated in your health account can be used only by you and members of your family. It's not like the mandatory solidarity of the public insurance and the national health insurance model, where all money collected go to one place, and it will be used by the people in need. So it is in fact young and healthy individuals from the entire country paying for the treatment of sickly old individuals from the entire country, people you don't know. So it's different. In the private insurance, you can spend money up to a single point. You might be denied coverage altogether if you are a very risky individual. So yes, it's not quite the same. Okay, so private versus public insurance in general. The US is the only developed country that still relies on this out-of-pocket healthcare model. As such, not all citizens are covered. The patient's access to healthcare is dependent on your incomes. Private insurance is obtained through one's employer. In fact, there is no competition in the American system between hospitals or doctors. This is out of the question. The competition is among insurance companies. So they will compete for the attention of employers. So once you get your job in the United States, you will be informed by your employer that the insurance company he has chosen for his company is this or that. And then you have to choose one of their packages. If you're not okay with this, you won't get the job. It's as simple as that. So there you run across such paradoxes in American healthcare when, for example, emergency care is considered basic human right. So emergency and intensive care are theoretically free of charge and available to all citizens. Specialized care is already, of course, paid and not available to everyone. So if you're some sort of illegal migrant, refugee, homeless person in the United States, when you need it, you'll get emergency care free of charge. But after you're stabilized in the intensive unit, they will throw you back on the street unless they find some charitable organization to pay for your further treatment. But if you are a hardworking American citizen belonging to the middle class, it won't be free of charge. In fact, you'll be sorry you've even called an ambulance because they will charge you anywhere from several hundred to several thousand. That's because insurance companies work according to the model of vertical integration. They have their own ambulances and emergency services, their own general practitioners, medical centers, hospitals, and they all work according to some internal prices set by the insurance company. So you have nowhere to go. You are insured very well. And when the time comes to receive some banal service, you receive it at exorbitant prices. You'll be really surprised. Okay. These things are mentioned already, and basically this is it. We may finish here. I will upload this presentation, and I will also upload presentations on the elements of the health system. So separate presentations. So be sure to read them as well. The presentations on hospital care, emergency and urgent care, and primary care. There will be separate presentations for them. Okay, any questions now? No?
No, doctor, thank you.
Okay, so have a nice day, everyone. And tomorrow we'll have our last meeting before the exam.
Okay. Thank you, doctor. Have a nice
Have a
day.
nice day.
See you. Have a nice day. Bye.
Bye bye. you.